All right, so this set of digital slides is going to represent tricho entities, so adnexal tumors that essentially start with tricho or something very similar. This can be a very confusing topic for beginners because everything sounds the same and it's really hard to kind of make sense of it. So we'll start out with an example of a very basaloid tumor. You can see when I say basaloid, what I refer to are these very hematoxylinophilic islands. So it takes up a lot of the hematoxylin. And it also is taking on this well-defined, almost palisading look to it. And it kind of looks like a basal cell in some areas, just at moderate power here. So when you hear the term basaloid, you can kind of think of that island of more purple cells. So from low power here, you see this really large lesion. This very thin material here is the epidermis. So you can see that the neoplasm is quite large compared to that thin epidermis. So you just need to go in and start to interrogate this. And maybe your first thought was a basal cell. And if you think about it, a basal cell is essentially a malignant tricho differentiated tumor. So when we think of things like trichoblastoma or trichoepithelioma, a basal cell is essentially just a malignant form of those entities. A trichoblastoma, which is what this entity is the most primitive form of a trichoblastic differentiated cell. So you get these cells that are really blue. They take up a lot of hematoxylin. If they were to differentiate, they could eventually become a part of the hair follicle, but they're in the most primitive state here. Trichoblastomas can get very large. And how do you tell the difference between a trichoblastoma and a basal cell? So a lot of it's going to depend on the context. So it could be a younger patient. It could be presenting in an area where there was no sun damage, things like that. The other thing is I've found that trichoblastomas can be quite large as well. But I would say that when you're on higher power, the stroma actually connects to the island in a way that's tighter. There's not a lot of retraction. And so if you think about ways that you can differentiate between a basal cell and a trichoepithelioma, that same factor of not a lot of retraction is going to play a huge role. So you can see as you kind of go around on high power, there's not a lot of retraction directly between the stroma and the tumor. It's very tightly adhered. The other thing is I've noticed when I look at different examples of basal cell versus trichoblastoma is that the trichoblastoma itself, the cells are actually quite homogeneous. You don't see a ton of pleomorphism. You don't see a lot of mitotic figures. Remember, a basal cell is the malignant form of a trichoblastoma or trichoepithelioma. So you, in a basal cell, are going to see a lot more cellular misbehavior, whereas here, you're not really seeing that atypia. These cells are pretty monotonous here. So that can really help as well. You can find different patterns within a trichoblastoma. So you can see on moderate power, there's a more dense population of cells. Over here, you have the cells more spread out with more of a fibrous stroma directly surrounding it. So just to give you a sense, in this large trichoblastoma, there can be different architectures, different cellular morphologies. Again, here you kind of have this more reticulated pattern. And you can kind of think about if a basal cell takes on a malignant form or develops an abnormal cell, then it can take on different patterns as well. So in a large trichoblastoma, you've got this kind of reticulated or adenoid pattern over here. Over here, you have more of a nodular pattern. And as you go over here, you might appreciate more of a chemetonecrosis that you could see in a lot of large basal cells. But again, this was not a basal cell, it was a trichoblastoma. So you can see a lot of parallels between a trichoblastoma and a basal cell. So this, to start out, is just to give you the most primitive neoplasm, and technically they're benign, but in reality, if this thing is growing, and it only takes one cell to undergo malignant transformation. So at the end of the day, this is large, it's growing, and you got to concise this and get negative margins just to make sure. Excision with negative margins is going to be the most useful because you don't want this thing recurring later and developing a malignant population. And you just have to take clinical scenario into consideration as well. Now, the differential diagnosis in this would include obviously a basal cell. You might find some little vacuoles in here, so you might consider some type of sebaceous carcinoma and do an adipofilin to make sure this thing is not having significant areas of sebaceous differentiation. Of course, a trichoepithelioma would also be in your differential diagnosis. Here, I don't really see a lot of keratin cyst-like formation, which would make me think more of a trichoepithelioma. Typically, trichoepitheliomas don't get this large. And the other thing is I don't really see amazing, what I call papillary mesenchymal bodies within this. But if you saw everything that I just mentioned, then you should definitely think about a trichoepithelioma. All right, so that is a trichoblastoma. Moving on to the next entity here. So in contrast to the last example of a trichoblastoma, you can definitely tell that this neoplasm is much smaller. As you go on higher power, you'll notice these basaloid islands again. They're taking up a lot of hematoxylin. There's some areas of peripheral palisading as well. And I hope you appreciate that the stroma is pretty tightly adhered to these outside basaloid islands. You can also see these foci of what appear to be keratin-like cysts or milia-like cysts, almost like a seborrheic keratosis in a way. Just showing you the architecture of the lesion. So your differential diagnosis, at least if this were an old person, it was on the face and it was growing, it was ulcerating, it was bleeding, you'd be thinking about the basal cell carcinoma just right off the bat. However, if this were a young person and not in sun damaged areas and it wasn't really growing, it was just kind of sticking around for a while, and you got this type of histology and you're noticing that the stroma is directly adhered, like I said, you're seeing these multiple milia-like cysts, and you may notice that it seems to be recapitulating a hair follicle pretty well. It's not as blue as many basal cells. You might find some areas that are looking like they're actually turning into a hair follicle more, where you're getting this almost like a matrix-like formation or follicular formation developing into a small island, these so-called papillary mesenchymal bodies. So taking this all together, and if you remember the discussion from the last unknown that we just had, you're probably considering a trichoepithelioma, and that's what this was called here. So the most important things to differentiate this, at least architecturally and histologically, when you're trying to separate out from a basal cell, is going to be those factors of the milia-like cysts along with the tight adherence of the surrounding stroma to the basaloid island and not direct cleft and retraction right next to the island, as you would see in most basal cells, along with areas that you might say, well, it's swirling, it's looking like it's a papillary mesenchymal body forming. Those are going to be your main differentiators. Now, in reality, if you don't have a lot of clinical information and you just have a small sample, it's smart to call this atypical basaloid proliferation, because you really don't, if you don't have enough architecture or clinical information, it may be hard to definitively say that it's a basal cell carcinoma or trichoepithelioma. And you have to leave the possibility open that based on the sampling, it could be either one. However, immunohistochemistry can definitely help you separate out statistically whether or not you're dealing with a trichoepithelioma or a basal cell carcinoma. So I like to get a BURREP4 just to show that it's positive, although you're going to expect to see that in both a trichoepithelioma and a basal cell carcinoma. So BURREP4 doesn't necessarily help you, but it can help you in the sense to highlight both trichoepithelioma or basal cell carcinoma, and it will not often stain other tricho entities such as trichomoma. So BURREP4 should be positive. The other thing is if you get a BCL2, typically BCL2 will be more positive in the outer cells of a trichoepithelioma, whereas in a basal cell, it should be homogeneously positive throughout the island, more so than not. It's also helpful to get a CK20 because CK20 highlights Merkel cells. And if you have areas of retained Merkel cells within the island, then that should also put you more towards a trichoepithelioma versus a basal cell, which typically would lack retained Merkel cells. So when you get all that together and you make the assessment along with the histology, the architecture, and the clinical scenario, then it can push you one way or the other. So in review, this was called a trichoepithelioma, and you should know the basic features of trichoepithelioma. Moving on. So here we have a punch biopsy, and you can see what jumps out to you. These milia-like cysts are essentially staring you right back in the face. So these have been likened to an owl eye pattern. In dermatopathology or in pathology in general, it's been tradition to imagine various shapes and create images of what you think they might represent. So somebody thought this could look like some type of an owl's eye appearance, but it's just very well demarcated keratin-like cysts. And some of them are exactly the same size, but depending on the cut, you're going to have larger ones, you're going to have smaller ones. And there doesn't appear to be a great island of tumor cells. You might notice that there appears to be a few areas that appear like basaloid cells, very small. From this power, you might even be debating, are these nevi cells or are they basaloid islands? So you could do a SOX10 or keratin to make sure that you're dealing with a keratin-derived or a keratinocyte-derived population as opposed to a melanocyte-derived population. But these are clearly keratin-derived cysts or milia-like cysts. So what is the name of the entity where you get many of these together clustering? It's in that tricho family again, but it's more towards the differentiated pole of things. So this is a trichoadenoma. Trichoadenomas are going to be defined as an adnexal tumor that's benign, but you've got these numerous cyst-like structures. And of course, adnexal tumors exist on a spectrum. And so sometimes you'll get variations on the theme, and you may get a trichoadenoma that has more of these keratinocyte-derived neoplastic cells here. But more often than not, a classic trichoadenoma is going to have more of these milia-like cysts here. So this is called a trichoadenoma. I would encourage you to find many examples of a trichoadenoma so that way you can see the different shapes and sizes that they come in, the different flavors that they come in, so that way you'll be prepared to be entertaining it on your differential diagnosis if they give you a digital slide of a trichoadenoma. Now, there does appear to be almost like a histiocytic population surrounding this. This is not, in my opinion, a keratinocyte population. This is a histiocytic population. You can see that they're forming almost like these little giant cells that you might get from or surrounding a ruptured keratin cyst. So, of course, this looks like a little small EIC or a little small milia. And so you can get that histiocytic population around these little cysts in a trichoadenoma. Moving on, so you have 8 small little sections of tissue to look at here, and from low power, I think you can appreciate that they essentially show very similar things. So just choose one at random and start going into it. And what are you noticing right off the bat? You're noticing these small follicle-like structures radiating from a large central pore. You see that? And then within this large central pore, you've got numerous hair shafts all collecting together. So people have likened this to daughter follicles leading into a mother follicle. And if you get it in the right plane of section, you'll be able to call this a trichofolliculoma. So the way I remember that is in a trichofolliculoma, you have a lot of tricho structures going into a large follicular ostia, so trichofolliculoma. It's the entity where you have several daughter hair shafts going into a large, mother shaft or whatever, but it's essentially just merging together. And clinically, you're going to see a tuft of multiple hairs coming out of one central area. So that is a trichofolliculoma. Now, just to kind of back up a bit, because we're going to get into a discussion here, The trichoepithelioma that I mentioned to you earlier, you can see often basal cells and trichoepitheliomas, as well as spiradenomas, which we will not mention in this data set, and cylindromas in an entity called Brooks-Spiegler syndrome. So Brooks-Spiegler syndrome is a mutation in the CYLD gene. So if you got an entity like this and they asked you what genodermatosis you should be thinking about, you should be thinking about Brooks-Spiegler. When you get to the trichofolliculoma, that's the one where you can actually have them in many different entities, but definitely be thinking about another entity called Birt-Hogg-Dubé syndrome. Birt-Hogg-Dubé is usually thought to be a mutation in the BHD gene, which is Birt-Hogg-Dubé gene. Sometimes it goes by folliculin gene. And Birt-Hogg-Dubé can have multiple things. It can have trichofolliculomas. It can have trichodiscomas or fibrofolliculomas, which we'll talk about. And it can have be associated with the risk of malignancy as well as pneumothoraces in the lungs. So these patients definitely need to be followed by pulmonology as well as like renal or nephrology because of the risk of renal cell cancer, unfortunately. Now, you may also get a digital slide of this entity and be asked to think of which genodermatosis it's associated with. So from this power, it may be impossible to 100% determine what you're looking at. So you'll probably notice the basaloid islands here, and you may be considering some type of basal cell carcinoma or some type of trichoepithelioma. As you go on higher power, though, you'll start to see this area of clear cell population. And it's reminiscent of the outer root sheath of a terminal hair follicle. So you've got a clear cell population. You also have this peripheral palisading of cells that has this outer thick eosinophilic basement membrane-like material tracing around the peripheral island here. And so when you have that combination of the clear cell differentiation along with the peripheral palisading and the eosinophilic rim, in many of the areas, not in all areas, but in many of the areas, then it should bring up the possibility of a tricholemoma. So a tricholemoma, which can be associated with Cowden's syndrome, is an adnexal tumor that essentially recapitulates the outer root sheath of the hair follicle, as I said. Now, it's possible to have adnexal tumors that have areas that resemble other adnexal tumors and also resemble a tricholemoma. But the classics will definitely show you this clear cell population and that thick eosinophilic rim. Tricholemomas are often associated with Cowden syndrome, as I mentioned. So the very popular way to remember that is tricholemoma, as a cow would say moo. And so you can remember tricholemoma for Cowden's. Now, if you thought that this looked like a basal cell, don't be upset with yourself, because many people who don't have the trained eyes of a dermatopathologist may easily jump to and confuse it with the basal cell. You might see some retraction and that peripheral palisading. Definitely, you might be thinking it. There's some other areas in here, though, that are collecting this eosinophilic globule material, which is essentially that basement membrane-like material that's collecting out here on the edge. And if you've seen that and it made you think of a cylindroma or spiradenoma, that's because you can see those eosinophilic globules in those entities as well. So let's say that your hunch is that this is a tricholemoma, but whoever you're looking at the slides with thinks it's basal or something else. What kind of immunohistochemistry stains can you recommend to help support your idea that this is a tricholemoma and not a basal cell carcinoma? So one thing that's very helpful is a BREP4. So a BREP4 is usually not going to highlight this as positive. That's in contrast to a trichoepithelioma and a basal cell carcinoma. So BREP4 would highlight trichoep as well as basal, but it would not diffusely highlight a tricholemoma. The other thing is, interestingly, CD34 beautifully highlights the clear cell population. And remember, CD34 typically marks endothelial cells within blood vessels. It marks more primitive derived cells. Many soft tissue tumors highlight with CD34. So if there's any doubt, or if you have a small sample, you definitely want to do those immunostains for CD34 and BREP4. So in this case, CD34 would be very positive in this whole area of clear cell differentiation. BRF4 should be pretty negative. Sometimes you can see some focal BRF4 positivity in more of the matrix bulb-like areas of hair follicles, but if it's not diffusely positive throughout the whole neoplasm, then that definitely helps support your suspicion that we're not dealing with any kind of basal cell here. So that's a trichomoma. Moving on to the next example here. So you have this really well circumscribed neoplasm. It's composed of pretty monotonous cells. Most of the cells actually have eosinophilic cytoplasm. You don't see a ton of clear cells in this example of a trichomoma. So this is another example of a trichomoma that's got a lot more lower amounts of clear cells, but there's still some clear cells. It's very monotonous. So in contrast to, like, say, a basal cell carcinoma, where you'd expect to see a ton of cellular atypia throughout here, more mitotic activity, here the cells are very monotonous. And you do see this area of peripheral palisading, which could bring up the idea, oh, are we dealing with a basal cell? But hopefully you'll notice this area of well-organized eosinophilic material along the rim. And so that will put you in that category of a trichomoma again. Just to show you an example of that trichomoma. Now, when you're taking an exam, you're definitely have to use your process of elimination skills. So they're going to give you other choices that are not going to be perfectly fitting. So trichoepithelioma, I'd expect to see a lot more islands than what I'm seeing here. I'd also like to see papillary mesenchymal bodies. Usually in a trichoepithelioma, you won't find these large areas of organized palisading, which is what we have here in this trichomoma. Now you can have inflammation within a trichomoma as well, which may make it hard to appreciate the eosinophilic island, or the eosinophilic rim rather. But as you get out here into these other uninvolved areas, you can see that a little bit easier. So this is another example of a trichomoma. And remember, CD34 should highlight most of these cells and a BRF4 should be negative. Now, if you're on a digital slide, you need to scan around until you really get this very nice rim, because most other adnexal tumors do not have this unless they have, a mix of a tricho or a trichomoma variation within them. And again, the correct answer is it's associated with Cowden's disease. Here is another biopsy. Again, you're going to see this clear cell population, and you're going to see this organized eosinophilic rim with long areas of really delineating and tracing out that peripheral palisading. And so again, to the untrained eye, you might be thinking about a basal, but look how homogeneous and monotonous the cells are. Not a lot of mitotic figures, not a lot of pleomorphism. Again, just another great example of how organized and thick that eosinophilic rim can be in a trichomoma. So this is another example of a trichomoma, more areas of clear cell cytoplasm to make you remember that it's differentiating from the outer root sheath. It's going to be diffusely CD30 positive, or CD34 positive rather. And I included a lot of examples of trichomoma because they are often forgotten by beginners. And so you have to remember to think about it, okay? And on this next example, you see almost a verrucous architecture in some ways to this lesion. So perhaps you thought of some type of verruca. These adnexal tumors might sometimes actually appear like warts on the face, the lip, the nose, etc. So let's say you have no clue what this is. You probably don't at this point. Then you're going to have to kind of go in on higher power and start to interrogate different parts of the island. So let's just start over here to the bottom left. All right, so you see that there is an organization. There's a clear delineation between the basaloid tumor. It's got some glassy cytoplasmic change inside, some squamous eddies, which suggests chronic irritation. As you can see that this lesion has been chronically irritated. There's overlying focal inflammatory crust and subcorneal hemorrhage. But that well-delineated pattern with that peripheral palisading, maybe a faint eosinophilic rim of material. We're just going to course along here and let you get a sense of what it looks like. Again, just traveling through the lesion to give you a sense of what it looks like. See if we pick up on any other patterns here. And then we'll go to the other side. Again, just giving you more of an examination. What does it look like to you? All right, so this is a pretty tough one, I would say, because it's got a lot of mixed features. I think that the fact that you've got a lot of these squamous eddies here, you can think about an inverted follicular keratosis. I didn't see a lot of cellular atypia here to make me think about a squamous cell carcinoma. I don't see true acantholysis as much as you would want to see in an acantholytic squame. And this numerous amount of squamous eddies would definitely have you be entertaining an inverted follicular keratosis. Oftentimes, inverted follicular keratosis look like upside down seborrheic keratosis. So I think that if you're debating an inverted follicular keratosis versus some other type of adnexal tumor, I think that that would be completely fair. And again, you can see on this side numerous squamous eddies as well. Lots of evidence that these cells are not malignant. There's irritation overlying this with some pigmented parakeratosis. All right, and so the diagnosis was actually here a tricholamoma as well, and so I just wanted to show you a different example of in real life how complicated this can be. And the reason why I think it was called a tricholamoma is because you do have some areas that look like clear cell differentiation, some areas of peripheral palisading. When you have a chronically irritated tricholamoma, you can get these inverted follicular keratoses. Again, in a chronically irritated inverted follicular keratosis or IFK, you can get the same thing. So this is something that would probably have to be descriptive, where you would say keratinocyte, or you could say endophytic keratinocyte neoplasm, see comment, describe what you're seeing, talk about focal areas of clear cell change and peripheral palisading with an eosinophilic rim, say that an irritated tricholamoma is possible. But given the numerous amounts of monotonous cell populations, many areas where you're not having that thick eosinophilic rim, and also just abundant squamous eddies, you can be thinking about an inverted follicular keratosis as well. Definitely, because it's important to just do a BRAF4 and show it's negative, and maybe a CD34 to highlight some areas where if you do see convincing CD34 staining, that can help push you more towards a tricholamoma versus inverted follicular keratosis. So this is more of a real world specimen here, where you can see it can be somewhat difficult sometimes to really classify these if there's a lot of secondary trauma to the lesion. So in this specimen, you may be asking yourself, well, I don't really know. This doesn't look like an adnexal tumor to me. This looks like some dermis, maybe this weird kind of architecture where you have this projection of tissue and then it kind of comes back down and folds in on itself and curves around. And it's kind of got this nondescript architecture. It's kind of hard to say, was it a pedunculated lesion or is it just sectioned weird? This is indeed an adnexal tumor. So clinically, these may present as small papules on the face of somebody with a syndrome. And the classic syndrome that you should know is Birt-Hogg-de-Bay. And so if the question that you were being asked seems that they are looking for some type of adnexal tumor and you're not seeing a lot of things going on higher power, you'll start to notice these strands of keratinocytes that seem like they're trying to organize into something. But in this case, you have mostly collagen. So you have a lot of just fibrous, almost some areas that look like fibromucinous stroma, some areas of thin keratinocyte islands reticulating together, some maybe overlying hyperkeratosis. Again, I hope you can appreciate these thin little branches of keratinocyte-derived islands here. And none of it looks malignant. So this was actually called a trichodiscoma from the Cleveland Clinic Library here. So this is, I would say, a good example of a trichodiscoma because it's predominantly more fibrous in nature. You do have some areas that look like they're trying to recapitulate a hair follicle, but mostly it's just collagen. And so trichodiscoma, the way I like to remember that is a disc of collagen. It's mostly just collagen and you don't have a ton of other adnexal material. But if this were cut in a different section, let's say this were cut along this section and you were viewing it 180 degrees and it was facing towards you, then you may actually notice that there are a ton of reticulated strands down here. They're all connecting together. And there is areas of surrounding collagen, just similar to this exact same stroma that we were just looking at. So again, this is the same slide. I just accidentally clicked to the next one, so I came back. And the reason that I'm showing you this and pointing out different features is because if it were cut in a different section, and according to Dr. Elston's textbook, you might see an entity that looks like what we call fibrofolliculoma. So fibrofolliculomas and trichodiscomas, there's a little bit of debate to say that they're probably very close to the same thing, if not the same thing. It is made up of a population of cells that seem to be recapitulating parts of the hair follicle. However, in a trichodiscoma, as I mentioned multiple times, you're going to have mostly collagen, whereas in a fibrofolliculoma, you're going to have mostly these interconnected strands merging together. And it can sometimes look like a fibroepithelioma of Pincus. It can sometimes look like a syringofibroadenoma, but fibrofolliculomas, again, are just probably a different orientation of a trichodiscoma. There are multiple other sources that you can look into on this particular entity, but the one thing that's agreed upon is that they often show up in Birt-Hogg-de-Bay. So we already talked about trichofolliculomas being very prevalent in Birt-Hogg-de-Bay as well. So just remember the folliculin gene. You can think about trichofolliculoma and the folliculin gene. You can think about BHD gene. That's the other name, or Birt-Hogg-de-Bay gene. And remember, they have a higher risk of malignancies. They have the risk of pneumothorax as well. Sometimes people say that it looks like a mitt-like structure. So you can kind of imagine this could be like a baseball mitt ready to catch the ball. It's interesting. I don't understand why, but when they're processed, they can sometimes look this way. I wouldn't rely on that 100%, but just to give you that disclosure that it seems like that's one of those buzz phrases that people want you to remember about this entity, and that has been taught over the years. Now, depending on what section you're looking at, you may also not see a ton of other diagnostic criteria. So if you look over here, you're going to see really just cross sections of pilar erecti muscle or erector pili muscle. You're going to see eccrine glands, subcutaneous fat, nothing that really jumps out, right? And so that's a reminder to definitely look at the whole slide, see if you can pick up on any more clues. And this type of design here should give you this trichodiscoma or fibrofolliculoma vibe. All right. Last but not least, another real world specimen here. So you can see from low power, we're probably on the scalp. You've got abundant antigen hair follicles reaching all the way down to the base of the subcutaneous fat. But you also have a cluster of glands as you go on higher power. You'll appreciate that they appear to be apocrine in nature. They've got areas of budding off of these cuboidal cells with abundant eosinophilic cytoplasm. So this is an apocrine gland. And there's numerous of them, numerous apocrine glands. You also have some areas of sebaceous lobules that don't seem to be associated with any follicle. And there's some other things I just skipped over, and I'll go back to them. Some more sebaceous glands here. And then looking at the epithelium, you get an area that is coming down, it's projecting downwards, it's got clear cell population, a very well delineated eosinophilic rim around it. And so what are you thinking? Rhetorical question. So you're thinking trichomoma. And so this is actually a trichomoma developing within a nevus sebaceous. But right next to it, you have almost a glandular appearing cell population. There's some apocrine differentiation here of these cells. You go on higher power, you might see more plasma cells within the cores of these fronds of projections lined by this apocrine ductal population. Just giving you another view of this, and it opens to the surface, the exterior surface here. So this was actually thought to be a small syringocystadenoma papilliferum, which is another entity I'll mention in my other videos, but it's definitely in your Adnexal chapters, and you should know about it. There's never a good time to start knowing about it because it's going to be something that they could easily test you on, and you'll see plenty in real life, whether you're in clinical practice or derm path practice or both. So this is a small little syringocystadenoma papilliferum, or SPAP, as many people call for short, just because it's much quicker to say it that way, but developing right next to a trichomoma. So trichomoma, SPAP, and as you scroll over a little bit more, you'll see this basaloid population. It's almost a small little nodule within the dermis. It's got some peripheral palisading. The stroma is tightly adhered. The cells are pretty monotonous inside. Maybe a little bit of clear cell differentiation, but for the most part, it's got a little bit of a mucinous production as well, and maybe a little cheminonecrosis in the center. This is probably a neoplasm related to your trichoblastoma, or maybe even an early developing basal cell carcinoma. It's hard to say. With that mucin production, definitely could be an evolving basal cell carcinoma. Like I said, that the cells don't look terribly neoplastic in nature. They look more monotonous here. So this was actually thought to be more of a trichoblastoma that was developing within a nevus sebaceous, which is pretty common. So trichoblastoma, SPAP, and trichomoma all within a nevus sebaceous. And again, that's just a cool, real example of a 4-in-1 for you. All right, well, that's all I have for this video.